In 2005, Hart came out with 5 facets of violence risk assessments. Um, the first factor, or facet rather, would be what is the nature of potential violence? Forensic psychologists should focus on different predictable variables, potentially have a different outcome if the focus is sexual violence, domestic violence, or general violence. So which type of violence are we talking about? It's going to have a different effect in terms of, and the different variables that we look when we're trying to assess. The second facet is severity. What is the potential severity of the violence? The final decision will be much different if the potential severity is murder as compared to a slap on the face or some other type of, we shouldn't say benign type of violence, but something that the risk is, or the severity of it is much less. And then frequency. How frequent will the potential violence occur? Someone who's likely to commit repeated violent acts warrants more consideration than someone who just had a single act or a much less severe act of violence. But how often has this person acted out in the past? What is the eminence of the potential violence? If the eminence of violence is immediate because of unmanaged symptoms of somebody who has schizophrenia, then the eminence of violence will decrease once the individual is medicated. So that makes a big difference. So this is really sensitive to, like it says, intervention and treatment. Is the person getting intervention? Is there treatment? Is there a safety plan in place? Or is it somebody who's off their meds? But once we get them stabilized, the eminence for potential violence will come down greatly. So likelihood, modern conceptualizations of risk assessment, move this out of the way, do not merely focus on the likelihood of violence, but also focus on additional factors that are equally important. We have some different ways of looking or studying a risk assessment, violence risk assessment. There's clinical assessments. They're informal, subjective impressions arrived at with human judgment, shaped by the professional's education or their experience in conducting assessments. Less reliable, but we often fall back on them, and they're still used today. Judges will want your clinical impressions and your subjective views of the potential risk of violence in the future. Actuarial risk assessment instruments, formal, they're based on algorithms. They're more objective procedures used to arrive at statistical conclusions. A few of the ones that are mentioned here: the Violence Risk Assessment Guide, you've got the ICT, the COVR, 3 different types of ways that we use actuarial risk assessment. Criticisms of the actuarials, more generalization. We tend to use them in all different situations, and we take what's based on groups and we apply it to individuals. The nomothetic nature, studying groups, is what actuarials are based on, compared to ideographic, which would be looking at specific individuals. So risk assessments that are actuarial are used in a great number of people and groups of people. So it's sometimes not real helpful in generalizing this onto an individual. One of the examples here is like, for example, male drivers, we pay higher insurance rates because females seem to be safer drivers on average. But if you are a male who prides themselves on driving by the rules very safely, you still fall in the group of high risk, unfortunately. So that's sort of the example of a major criticism of actuarial. They don't consider management or treatment issues as well. They're not focused enough on that. They don't take that into consideration when they're doing the assessment. Structured professional judgments, formal but flexible predictions based on empirical literature. Some of the examples: historical clinical risk management 20, the sexual violence risk 20 are sort of a mixture. They're structural professional judgments, but they also have scales built in, or lists that we fill out, that we classify with, identifying a list of important risk factors and guidelines for using them. Scoring can be similar to actuarial measures, but clinical judgment is encouraged. May increase the chance of bias. Support for structured professional judgment is promising. We're having more of these are developed, and they seem to be helping. It says at the time, though, there's no clear consensus among forensic psychologists as to the best approach for conducting violence risk assessment. There really isn't. Risk and protective factors, some of the static factors, these are historical typically. They're fixed, they don't change, or often don't change if they do much at all. History, past violence, young age, psychopathy, history of employment instability, substance use, major mental disorder. These are fixed, mostly historical factors. Very different to what we call dynamic factors, which can change. They're clinical in nature. A few examples: lack of insight. Somebody can gain insight into their impulsiveness, for instance, and learn how to better regulate their emotions and not act out violently. Negative attitudes can be shifted more towards positive. Psychiatric symptoms can be treated and sometimes are actually in remission or gone. Behavioral affective instability, so the way we behave, the choices we make with our behavior. Affect is our emotion, how we're basically able to better manage our emotional states. Unresponsiveness to treatment. Yeah, I mean, we don't, some people don't respond, and as a result, the risk can go up. Risk management, a risk management approach definitely encourages intervention or treatment instead of a simple traditional assessment. This is sort of your risk assessment or traditional way. We look at both static and dynamic. There's just one administration of the assessment. Its purpose is to identify potential for future violence. This post-assessment control is a problem because we don't have control over what people do when they leave. If we're not putting a safety plan into effect, or we're not asking for them to, or recommending highly that a treatment or some type of help is put in place, then yeah, we have less control. Where with risk management, we're paying attention to that. We're putting more control into place. We're recommending treatment. We're recommending ways to help an individual. So hopefully that'll decrease the chances of acting out in a risky manner or a violent manner later. When we do this many times, we'll administer it. We do it initially. We do a follow-up, another follow-up. We continue to monitor and track. So the idea of risk management, again, reduce likelihood of violence through assessment and treatment combined. Protective factors, characteristics or conditions interact with risk to reduce violence. Offer an explanation of why individuals who face the same degree of risk may be affected differently. Protective factors do not guarantee that an individual will not become violent. It simply reduces the probability that people facing a risk factor or factors will become involved in violence. Some of the types of factors we're talking about here: perceived social support, perceived, see, it's perceived, our belief, perceived emotional support, social support, spending spare time with friends and family, belonging to a group, club, or organization, involvement in religious activities, closeness to others, relationship competence, proactive behaviors and initiatives, having a place to stay after release, private accommodation, stability of dress, having an income, able to financially manage household well, being in work, training, or education, having had any job since relapse or release rather. Yeah, these are all part of protective factors that we put into place with treatment. And accuracy of risk assessment, it's difficult, and here's why. The accuracy is not always so good. It's difficult to follow up. Violence is a behavior that is not readily reported or easily identified except when in extreme situations. Collection of follow-up data necessitates following individuals who tend to be transient or less likely to remain stable or have stable public lifestyles. The measurement of violence itself, historically measured by formal legal charges and convictions for violent crimes. However, doing so misses the majority of violence perpetrated because most violence never results in legal charges, and we miss that. So we're not able to follow up, we're not able to evaluate and study most violent situations except for the more violent ones, or the ones that when there's legal charges and convictions. The definition of the violence, there's great variability. Comparing results across studies have divergent definitions of violence. Pull this out for a second. Violence is not, it's also a low base rate behavior. Violence is not frequently occurring. It's not a frequently occurring event, therefore difficult to study and maintain accurate estimates of risk. So when are we good at it? when can we really do a better job? Predictions are for short term. It's much easier to assess whether a patient is going to become violent over 48 hours or 14 days than over a 48-month or 14 years. In the short term, we can predict it a whole lot better, or we can assess it. I'm going to keep using the term predict, and we want to avoid prediction. A number of factors can change the longer period the risk assessment administration is to cover. So if we do a one-time assessment over years, chances of a person losing a job, getting a divorce, drinking again, etc., these are some risk factors that might cause somebody to become violent again. The possibility goes up. Environmental settings for which we have past data. Individuals incarcerated for years in a prison who are chronic patients in a mental hospital are likely to have extensive documentation that provides information about their past behavior, which helps us to better assess whether they're going to act out violently again. And then high base rates, frequency of violence. Assessing risk violence in the general public will always remain low because violence is relatively rare. However, base rates are heightened when risk is assessed in situations in which previously violent individuals are assessed. So those, again, that we have access to are the ones that we can make better assessments about their risk level. Communicating it, we want to communicate it. It says a psychologist prefer to communicate in terms of risk management, identification of relevant risk factors, and the potential interventions to reduce the threat of these risk factors. Categorical risk levels. We prefer to say the person is at high risk, medium risk, low risk, rather than they have a 10% chance of becoming violent or 80% chance of becoming violent. We want to stay away from that. So that kind of sums up some of our information, and I hope this video lecture was beneficial and helpful to you. Thanks.